Hi, I'm Dr. Chris Cannon, and on behalf of CME Outfitters, I'd like to welcome you and thank you for joining us in today's educational activity. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing medical education for clinicians across the globe. There are several really neat features that are being offered by CME Outfitters. They're providing resources for both patients and providers. So first, CME Outfitters would like to try and integrate digital health tools, and so they partnered up with a group called Pack Health, and will offer to 75 patients personalized digital health coaching for up to 3 months. Then for clinicians, CME Outfitters will be offering an e-consult service at no cost for up to 100 clinicians who sign up. The group Arista MD will be providing the e-consult service to clinicians at no cost for a 30-day period. And then finally, CME Outfitters has developed 2 patient education tools. One really nice whiteboard animation that describes non-valvular atrial fibrillation, its symptoms, risk factors, and treatment, as well as a downloadable list of questions that the patient could ask their doctor or healthcare professional regarding non-valvular atrial fibrillation. So, I want to introduce us as a group. My name is Chris Cannon. I'm the Education Director at the Cardiovascular Medicine Institute, or Innovation at Brigham Women's Hospital, and a professor at Harvard Medical School. And looking forward to an active discussion that will focus on strategies and tools for improving care. And we'll begin with good friend, colleague, and world expert, Dr. Elaine Heilich, who's the director of the Thrombosis and Anticoagulation Service at Boston Medical Center and a professor of medicine at Boston University School of Medicine here in Boston. Also want to introduce Dr. Deepak Bhatt, another good friend and colleague, and he's the Executive Director of Interventional Cardiovascular Programs at Brigham Women's Hospital and the Heart and Vascular Center, and also a Professor of Medicine at Harvard Medical School. So want to welcome both of you for this terrific program, and we look forward to being a global community with all of you who are joining online. And why don't we move on to our second segment? And here the learning objective for this segment is to look at what are ways that we could increase the rate of detection of non-valvular atrial fibrillation by looking either at opportunistic screening or more systematic screening in a primary care setting with our ultimate goal of trying to reduce the risk of stroke. And so we'll again begin with a question, and here we're getting into a little bit more newfangled area of how to do screening with lots of different tools. And so we'll ask the question of which of the following is currently recommended in guidelines for routine systematic screening for atrial fibrillation. A would be a 12-lead ECG, B, smartphone apps, automated blood pressure measurement, apnea index, or none of those things recommended. Well, Elaine, why don't we turn to you and get an early answer on what is in the current recommendations for screening?
So, incredible timing of this program. There is a body of individuals that sort of looks at evidence, at least the extant evidence, and comes up with a promulgation, usually fairly conservative, about where they think, we should be putting our investment. So that the U.S. Preventative Services Task Force released the final recommendation statement on screening for atrial fibrillation with electrocardiography, and the task force found insufficient evidence on screening for atrial fibrillation with electrocardiogram to prevent stroke. And I think that the group is charged with a finite amount of money in the healthcare system. Like, how can we make this one cost effective? And I think cost-effective, any screening program, it's going to be most cost-effective if you're limiting it to the individuals that are really at the highest risk of having the entity. So we've kind of already discussed about, really large groups of individuals that have that higher CHA2DS2-VASc score. And then the other thing, when you look at that sentence, the task force found insufficient evidence on screening with electrocardiogram to prevent strokes. And like here, I just realized that you can diagnose AFib, but if you're not doing the next things that you need to be doing with your atrial fibrillation, i.e. seeing your physician and inquiring about my CHA2DS2-VASc score and should I be on an anticoagulant, what are my risks, then you actually may not ever be able to demonstrate that the detection of it is preventing stroke. So, I think that the screening literature, the screening studies are really just coming to fore now because we haven't been focused on the pre-stroke care and diagnosis as much as we are, I would say, in the last 5 years. So I can't imagine that this isn't going to change or be shaped over the next few years.
That's terrific. And Deepak, we have ECG screening for young athletes, and certainly. And what do you think about sort of ECG? What should be the threshold for adding that into a doctor visit of any type?
I mean, it's a great question, and as Elaine sort of alluded to, if you're doing the annual ECG on everybody, the cumulative costs of the healthcare system, aren't trivial. On the other hand, I have a little bit of a different viewpoint because as an interventionalist, there's nothing more that I hate than getting called from the emergency department saying, look, presume new left bundle branch, take them to the cath lab. And if there were an old ECG, it would make that aspect of my life easier. So I kind of do like the ECG as part of that annual visit for at least the middle-aged or older individual, but will concede that there's no data supporting it. It could lead to a series of expensive tests, potentially even leading to complications, including very rarely major complications if you see a left bundle, as I just alluded to, but the person's asymptomatic, and now you get a stress test, which probably you shouldn't. That shows something. They get a cath, maybe they have a bleed, very rarely a stroke. So, I get it that just the non-evidence-based screening can have downsides, but on the other hand, you do pick up some folks with atrial fibrillation. It does give you a baseline. So it's, as Elaine said, it's all how you use it. If you then, get an abnormal ECG and cath everybody, then that's probably not a good thing to do. But if you just use it for what you meant to use it for, that is to establish a baseline, maybe look for AFib, even though that goes against the guidelines, I don't think that's unreasonable.
No, it's with this sort of, what do we do here in screening? There's not much evidence. We'll touch on a few trials. What would you see as sort of the goal of screening? Are there any people that have looked at the potential?
So, I think that there's an interesting study that was published not really very long ago, which is why I'm a little surprised that the U.S. Preventative Service Task Force, that here we have data from this RIC stroke and registry. And for me, as a practicing internist, this is all I need to know. In this study, they found that about 33% of ischemic strokes were due to atrial fibrillation. And only 16% of those had received an anticoagulant in the previous 6 months. In addition to that, 8% of patients in this registry had atrial fibrillation that was not previously known. And that's actually a low number because I believe most of the literature I've read has stated about 15% of all strokes are actually the first clinical manifestation of atrial fibrillation. And I would hope that that would not be my first manifestation or clinical manifestation of my AF would be a stroke. And then another, I think, very important thing to grasp is that in this study, 8 to 28% of patients with ischemic stroke noticed their symptoms when they woke up from sleep. Which this concept of a wake-up stroke, about 12% from other literature, I think it's about 12% of the time that an individual has a stroke, probably for different reasons, cortisol changes, whatever. But I think these are the reasons that we would want to know, I would want to know, to prevent these potentially devastating outcomes, and then hopefully, again, get the therapy that you and your physician, family members decide is the most important for you.
Yeah. Well, screening definitely can be, and there's sort of two broad approaches. And Deepak, do you want to touch on sort of targeted versus systematic and sort of the opportunities in each approach?
Yeah, absolutely. So targeted screening really refers to identifying the appropriate setting and cohort of people to assess. Examples might be a flu clinic, for example. A hypertension clinic, that might be a little higher yield, in fact, just because of the fact that hypertension and AFib can travel together. And other sorts of places might be a sleep apnea clinic, because again, there's a proportion of folks with sleep apnea that will have AFib. The two are interrelated. And those are just some examples. Opportunistic screening, on the other hand, could occur in any setting. So a walk-in clinic, Community pharmacies, some have advocated that approach, or different sort of health care affair events. I mean, that can be a way of picking up some AFib. All are potentially useful. None are really evidence-based. That is, nobody's done a 1,000,000-patient study and said, walk into a flu clinic and you're better off having your AFib detected than not. It's just sort of the challenge. For sure, people that have their AFib detected, I think it's a good thing if it's sustained AFib. I think the challenge is, some people have more transient episodes of AFib. Some people may be misdiagnosed as having AFib in these settings when they don't really have it. And there's a potential for downstream unnecessary testing. That's the downside.
Mm-hmm. That's great. And are there people that you'd think about targeting sort of based on clinical or, demographics or their prior history that would be reasonable to think about the screening?
Yeah, I think so. I think people over the age of 65 makes a lot of sense to do it there. And by screening, I mean, at a minimum, I would like to think people are still doing the physical exam, even though that doesn't have a lot of evidence either. Maybe that should go out of the guidelines too. But I'd like to think people are doing a careful pulse check for both rate and rhythm, blood pressure checks, that sort of thing. So that would happen. And I think an EKG is part of that. I don't think that's such a bad thing as part of the annual physical. I'll probably get in trouble for saying that because it violates the guidelines and everything, but it had been standard practice for a long time. I think people that are just at high cardiovascular risk, even if they're not over 65, it makes sense. As I showed from the REACH registry data, a lot of those risk factors and AFib travel together. So I think it makes sense if someone's had hypertension for a couple of decades, even if they're under 65, there I would really be concerned about AFib. And there I think, the threshold for screening really should be much lower in terms of an ECG. Mm-hmm. And there are other things too, other sorts of obviously if they have heart failure, I imagine they're going to get a 12-lead ECG anyway, but if for some reason they're not, they should looking for AFib and other sorts of potential abnormalities, and sleep apnea, kidney disease. I might throw in people that are diabetic or obese as well.
Yeah. And then the other approach would be to make this a little bit more systematic. And there have been some studies that are starting and others that we'll touch on getting going. But do you want to comment on this as sort of a systematic approach?
Yeah, this is some work that was published in Circulation a few years ago, the Stroke Stop study in 7,000 or so people around the age of 75. And what they did was use self-activated handheld single-lead ECGs, and that returned a diagnosis of AF in about 3% of all patients just over 2 weeks. So those are people that wouldn't have known they had AF were it not for this. So I think that that's potentially a useful approach. And again, the question that remains unanswered is, how actionable is the information? What would you do with it? But that critique could be made of every test that we're getting. Stress tests and so forth. I mean, you're just getting stress tests in healthy 20-year-olds, and they're coming back abnormal every now and then, and a false positive, and you're cathing them. That would be a bad judgment of how to use a non-invasive modality. So I think this is an interesting study.
Yeah.
Right, and it's important to validate that diagnosis, as it clearly states here with the electrocardiogram. And I think what's a little remarkable about this study is that 3% in 2 weeks.
Yeah, it's a lot.
2 weeks is a very short interval. So I do think that there's a population in which it makes sense to really be a little more systematic in the screening approach.
Yeah, in the absence of anything else, I mean, age is always a good marker of risk, and obviously the burden of AF is particularly high in older folks, and then the risk of stroke is also substantial.
Yeah. And if we did adopt some type of a screening program, well, how could that impact on outcomes? What would be sort of the play of this?
Well, I mean, I think the obvious. I mean, what is our most feared outcome with atrial fibrillation? Well, it's stroke, and I do think that would be a very important continuum of care if you were diagnosed to really, go and seek the advice that you need and the treatment that you need. Clearly, for me, it's yet another opportunity to tell you, Chris, you need to really work on that 75 pounds that, not you, Chris, but that you put on, because, I mean, that is going to be fueling the burden. There may be more atrial fibrillation, and I just really think it's an opportunity to bring our patients back to the table. This is where you are. Let's see if we can't have some real impact here with your lifespan.
Yeah. All right, well, let's go back to the polling question that we had, and here we were looking at which is recommended currently for routine systematic screening. And the audience said 60% 12-lead ECG. So I think it's the Deepak Bhatt guidelines here and I think very thoughtful, but I think from a sort of public health screening, there isn't currently that evidence that you'd be doing way more ECGs than they thought would be cost effective.
Yeah, absolutely. I mean, I think it reflects the wisdom of the crowds, right? I mean, that's what people are actually doing. But it's not the right answer for, a board exam or something like that. I mean, the task force guidelines are very clear not to do routine, non-directed ECGs.
Yeah. Well, this field, I think, is evolving quickly, and there's been news of the Apple Watch was the latest screening tool, but there are a lot of different tools. You want to sort of touch on the array of things that we could bring to bear?
Well, the one thing I really want to emphasize, and I feel strongly about it, is when a patient comes into my office, I mean, my God, unconscionable to not be checking vital signs. I think that's just a critical, basic part of caring for individuals. So, I mean, the heart rate, clearly, the regularity of the pulse, because I would say most of the patients in the last 6 months that I've diagnosed with atrial fibrillation, it was in the office when they were coming in for a different reason. I noted the irregular pulse, listened to the heart, was able to get it on a 12-lead EKG. But again, that's a screening bias for the patients that actually come in for sort of a routine check every 6 months or once a year, what have you. But clearly the automated blood pressure measurements is important, single lead ECG screening. I think with the difficulty in this whole field right now is that if, like, sensitivity means, how many of these entities are you able to pick up? That's your sensitivity. So it makes sense to me that the higher you want your sensitivity to not miss one of these cases, the specificity or the false positives is often the trade-off, because now you're opening up the universe of all of the things that might within there have some atrial fibrillation. And I think some of these high estimates of specificity I do question just a little bit, because it's hard to have the 99 and the 99 when it comes to something like an arrhythmia. I don't know, Deepak, if you agree with that, but
I agree.
Yeah, and we have one of the devices actually has gone through a formal FDA approval. And so this, as pictured here, is the Alivecor device that does a single lead ECG. And there are then, as a watch version of this, and then the Apple Watch would be the single lead ECG. And to have a diagnostic algorithm in the software is really part of the key. But I think, as you say, we have sort of the initial studies gone through FDA approval, but now we need sort of the real world, bigger studies. There are other sort of more simple things. And Deepak, I think you've been playing around with a heart rate monitor on your...
I have, and so first let me just say I don't have any sort of financial interest in this app or company. I only downloaded this 5 minutes before the program. It was easy to download. It was free. And I'm not saying to do it, but the reality is it doesn't matter what I think, because patients are going to be downloading these apps and using them. Not just patients, even just healthy people walking around. So there's going to be a ton of people. So it doesn't really matter whether I think it's a good idea. It doesn't matter what any of us think with that respect. This is the reality. It's the future, right? I mean, it's everybody's got an iPhone or something like that. So let me go ahead now. And again, this was just downloaded for free about 5 minutes before this program started. And I've got my finger on where the camera is, and I'm going to hit the start button here. This is the cardio app. Just went to the App Store and downloaded it.
So you got a good pulse there, it looks like,
It does. It's interesting. When I did it before, it was 60. I guess even without knowing it, my pulse is up because we're on live TV, I guess.
Yeah, there you go. Yeah.
But it was about 58, 60 before. Very interesting. But at any rate, this isn't to detect AFib. This is just to detect the heart rate, and it shows the heart rate. It does show, the rhythm in a sense. But it's not really designed for atrial fibrillation detection.
But,
at least
the
as best I could
tip-off
tell.
would be oftentimes a rapid heart rate, is
Yeah.
how atrial fibrillation often presents. That's what the palpitations are, the feeling of breathlessness. Sometimes this feeling of lightheadedness, can be because your heart rate is too fast, and that is also sort of a marker of AF. So, important, just that.
Yeah. Well, I think it is the future. Just yesterday in clinic, one of the patients had one of the, the iPhone watch or the smartwatch, and we were looking through the last 2 months of her heart rate, and it's just kind of a whole new piece of data that we can use in the office.
It is, but of course it'll be a mixed blessing for us from the physician side, right? Because it could lead to us being inundated with data, some of which could be actionable, but in a sea of data that's probably not actionable.
And I think that's a key thing. This was an interesting study looking at community screening. Do you want to comment on this one? I guess this was trying to look at using an iPhone ECG, but in pharmacies. And so you had mentioned, Deepak, sort of one of the systematic ways of just, if people show up in a pharmacy, you can go to the little booth on the side, and this picked up a few cases, I think. It was an interesting study overall. One of the questions that comes up is then, who takes action? And that is building a system around this, I think, is a key part of it. If something is diagnosed, who gets alerted? And so one of the system we looked at earlier, you have to log in who's your doctor to get any kind of alerts. And
right, and
like
I think that's obviously the critical piece, and that may have been really what the U.S. Preventative Services Task Force was touching on, is that, it's great if everyone wants to be involved, they should be in your health. For goodness sakes, the most important thing is your health. But if you have that, I mean, you really do need to act on it, and there needs to be a loop or no fragmentation in the care of that once it's diagnosed. And I think what you're doing and how you're acting on that is part of the reason they may not have shown yet any decrease in outcomes, especially stroke.
Yeah, because you can go to a pharmacy right now and get your blood pressure checked for free in many places. There's little cups you can stick your arm in. I like to go in and do that myself. But do people always act on that information? It's really what Elaine said. The loop has to be closed. I mean, maybe I'm checking my blood pressure is high if I don't do anything, or if there's no prompt to do anything. Yeah. So, the information, I think, potentially could be useful, but more important is how is that information utilized and integrated with that person's overall health care.
I think the other interesting point here, too, is what about the sea of people who aren't digitally savvy, or, people that really don't want to be tethered to this type of monitoring of self. And we can't, lose sight of, all of those individuals that really just, this may not be part of their approach to their health or whatever. So I think if we would find really super convincing data, then we would then maybe say to our patients, well, maybe we should be thinking about some of this stuff, even though you don't currently have your laptop or you don't have other things. So it's important, the tech savvy, I think, is important to break down those barriers.
Yeah. Right. Although, those things are changing. That is, with the younger generations. I mean, kids in middle school now have cell phones, maybe even in grammar school. So there's just such a wide penetration of these handheld devices, and such comfort with even sharing data, it seems like. Maybe a little bit too much comfort in terms of not worried about the privacy aspects of sharing data. So I think in the future there'll be such penetration of these devices globally, and such comfort with having data downloaded that, it's going to be part of the future of healthcare. We've just got to figure out, can we do it in a way that's more scientific, instead of just everybody's recording everything and just sending everything to their doctor or not sending it. How can we use this information and prove that it actually improves outcomes?
Yeah. I'll just share here, this is an evolving thing. This was a neat study from UCSF, but 51 patients, and, had very high sensitivity and specificity, but I think we have to bear in mind this is in carefully selected patients. And so I think we'll look forward to larger studies in this area. Another study looked at wearable continuous ECG monitors, and those have gotten nice and small, they're like an oversized Band-Aid, but was studied very carefully in a large study, and was able to pick up new AFib in just about 4% of people. And so I think this is a new way that we can, these are ordered in the office, at least I do in some patients.
So, Chris, one thing I would like to add is that, you know, one of the groups, the Cryptogenic stroke group, I think is a critical group as well, where I think we have very compelling evidence from the Crystal AF study that among individuals who present with a stroke, you've looked for AFib, you haven't found atrial fibrillation, the patient's been on tele during that stroke admission, but individuals in that study who had some type of like an implantable, you know, right under the chest muscle, subcutaneous, a tiny monitor, that they were able to really pick up AFib even at the 30-day mark, 6-month mark. I mean, and it wasn't trivial. I believe it was up to at least, was it 12% in Crystal AF?
Yeah, it was pretty high.
So, I mean, different population, but again, I think we're moving, especially for a stroke population, because that would change management.
Yeah, well, I want to thank you. This is a rapidly evolving space, but you know, with really promising, and it makes sense. So as Rachel Maddow says, watch this space.